This is the sixth and final session of this PPCL Echo cohort. This is our agenda today. We'll do our best to adhere to the schedule. After I complete the housekeeping announcements, our facilitator, Dr. Olivier, will lead us in introductions and then pass to Dr. Katie Queen, who will present our case today. If you have the chance to please put your name, credentials, and affiliation, the agency that you work for in the chat. That way for attendance and CE purposes, we will have record of that. Once Dr. Olivier leads us in introductions, Dr. Queen will present the case presentation. We'll open the floor for clarifying questions for participants. And then from the hub team, once all the questions have been answered, we'll transition to providing recommendations. We will summarize all these recommendations and send them to Dr. Queen, so you don't have to worry about taking too many notes. Then we'll have our presentation of the didactic followed, presented by Dr. Finelli, and then we'll wrap up with announcements and close this cohort. Dr. Olivier, would you like to introduce everyone?
Sure. Good morning, everybody. I think we've all are familiar with each other's faces by then, but we'll go ahead and reintroduce ourselves. I'm Dr. Olivier. I'm over here in Lafayette, Louisiana in private practice. I'm a child and adolescent psychiatrist, and I'm the facilitator, so I'll be making sure that we run on time and kind of gently reminding everybody throughout the presentations about protected health information. Lena, do you want to go ahead and introduce yourself?
Sure. Hi, everyone. My name is Lena Reguette. I am an LCSW and the mental health consultant for the provider-to-provider consultation line. And I'm also a hub team member with the ECHO. So I'll be monitoring the chat and providing support for the hub team and the spoke members.
And Jody, do you want to reintroduce yourself?
I'm the program manager for the provider-to-provider consultation line. I am also the coordinator for this ECHO, and I'm an LCSW by trade.
Lisa?
Hi, I'm Lisa Spence. I'm the pediatric nurse practitioner, part of the hub team, and I am in primary care, do behavioral health in St. Bernard Community Health Center.
Thank you. Sienna?
Good morning. I'm an LCSW and also the mental health consultant for provider-to-provider consultation line.
Thank you, Sienna. Paulette?
Hi, Paulette Carter, social worker, and I'm the program manager for the mental health consultation programs for the Bureau of Family Health.
Thank you. Dr. Queen?
Hi, I'm Dr. Katie Queen. I'm a general pediatrician, and I work in Our Lady of the Angels, a rural pediatric clinic in Bogalusa.
Thank you. And Marcella?
Hi, I'm a general pediatrician. I work for DePaul Community Health Centers. It's a QHC in New Orleans.
Sorry, Dr. Hauser. All right, I think that's everybody. We will move on to, but we have a presenter, Dr. Finelli, today.
Hey, hi everyone. Good to see everyone's faces. Hey, Dr. Olivier, good to see you.
You too.
All right, so should I go ahead and get started, Jody?
Yes, go ahead and I'll promote your slides whenever you need.
All right, thanks. You can advance to the next slide. So I was asked to talk a little bit about perinatal depression and perinatal depression screening, and I'm sorry I missed the case. I missed the whole presentation, but I caught the tail end. But it sounds like there is a caregiver with anxiety. So, but I wanted to make a quick note before we talk about screening, just a note about inclusive language. We know that not all birthing people identify as women or mothers. Language matters. We are trying as a program to incorporate more inclusive language. I'm going to be citing some data and studies that are specific to people who were basically assigned female sex at birth and assumed to identify as women. We're obviously lacking data overall for gender diverse birthing and parenting people. Next slide, please. All right, so before it's difficult to talk about this issue of perinatal mood and anxiety problems without talking about care gaps. Paulette and I were just talking to to legislators this morning about this, but mental health problems are the most common complication of pregnancy. They affect up to 20% of women in the perinatal period, so that's from conception through the first year of life. That rate is higher among lower income patients and patients who are minoritized. Despite the fact that this is such a common complication, studies suggest that actually less than 50% of patients with perinatal mental health problems are identified by their frontline healthcare clinician. And then even when we are identifying mental health problems, we're not doing a very good job treating them. So 75% of patients with perinatal mental health symptoms go untreated. And the fact is that not enough psychiatrists to care for all of the patients who need treatment. This is the case when it comes to child, as Dr. Olivier knows. And all of you pediatricians know, there just aren't enough of us to care for all the patients whose pregnancies have been historically underrepresented in clinical research, but also in clinical training. So my next slide kind of goes into a little bit of detail about this. I think this surprises some folks outside of psychiatry to know that the majority of psychiatry pregnancy training programs don't incorporate any kind of substantial training in reproductive psychiatry or perinatal psychiatry. And this is despite the fact that as psychiatrists, half of our patients usually are female. Most females will be pregnant at some point in their lives. Most females menstruate. And yet the study found that an alarming percentage of program training directors didn't feel like this was important for their residents to know. Psychiatry residents don't need to demonstrate any kind of competency in this field. The good news is that there's increased focus, there's increased fellowship training in this specialty. But if we talk to our colleagues in OBGYN, they surprisingly feel like their residents do not come out of training equipped to manage mental health concerns in pregnancy and postpartum. Next slide. So why are we talking about this in a pediatric tele-echo? Well, there are a lot of things that can be done in the pediatric setting, and we're going to really be focused on screening. So really the pediatrician's role is one of screening, early identification, brief supportive interventions in the pediatric clinic setting, referring for mental health treatment, and then in cases where the caregiver is the patient, in the case of an adolescent pregnancy, for example, the pediatrician's role might include starting first-line treatment. Next slide. Okay, so a little bit about screening. I mean, pediatricians probably have the highest burden of the screening placed upon them. There's so much to screen for, but in medicine, we screen for disorders that are prevalent, that we can identify with low-cost measures, that cause impairment, and that are treatable. So I'm going to go through these in my next slide. So I think I made the case that perinatal depression and anxiety are common. They are, we do have screening tools to identify them with low-cost measures. Next slide, thanks, Jody. And we know that they cause impairment. So I know that this is not news to this group, but perinatal depression and anxiety have been associated with preterm birth and low birth weight, higher rates of emergency C-section, maternal suicide. Maternal suicide is a leading cause of pregnancy-associated death. And then we also see negative infant outcomes as well. So not just observable outcomes in infants, but also even biological changes. Infants of mothers with prenatal depression have demonstrated frontal EEG asymmetry, which is a reliable index of emotion dysregulation. So we actually see biological changes, including low vagal tone, abnormalities in that stress response system, which is already being developed this early. Next slide. And we think that at least some degree of these associations are mediated, at least in part, by parenting challenges and parenting behaviors. So moms with depression are more likely to report feeling less competent, are more likely to be observed with irritable or disengaged interactions with their infants, fewer interactions overall. We know how vitally important those parent-infant interactions are in developing that infant's capacity for emotion regulation, really critical. But we see differences in health patterns too, so lower rates of breastfeeding persistence, lower rates of timely well child care, lower use of safety measures like car seats, and higher rates of physical punishment, including in infancy. This was at 12 months. And then if we look even further down the line, infant development and even child development. So at 9 months, studies have found reduced social engagement, more fear and negativity in interactions. And then toddlerhood, really through adolescence, studies have found associations with higher rates of internalizing problems like depression and anxiety, which we were just discussing today, and increased risk for externalizing problems, ADHD, behavioral difficulties. Next slide. And I didn't want to leave the non-birthing parent out. There's less research on paternal postpartum depression, but it absolutely exists, affects up to 1 in 10 fathers. Some studies have found higher rates, and the rates do increase when the birthing parent has depression. Paternal postpartum depression has been associated with parenting problems, increased couple conflict, increased risk for depression in the birthing parent, so there's this bidirectional risk. So we know that with a mom with depression who's struggling maybe with her relationship with her infant, yes, a non-birthing parent, other relationships with trusted caregivers can buffer the impact of that, but there is a risk here that the non-birthing parent may also have depression. And then again, higher rates of physical punishment. Next slide. So finally, the last point of the things that we screen for disorders that are treatable. We have evidence to support the efficacy of screening itself, supportive approaches, certainly psychotherapy and medications. Next slide. So the question becomes when to screen. So what our colleagues in obstetrics are advised to do is to screen at least once in the perinatal period for depression and anxiety, and to screen for mood and anxiety at that comprehensive postpartum visit, which is usually around 6 weeks, sometimes earlier or later. Problem is, as many women don't keep that comprehensive postpartum visit, perinatal depression can present earlier or later. So this is a study from 2013 of women with perinatal depression or anxiety. 27% had it when they entered pregnancy. You can't see that, but it's about 32% develop symptoms during pregnancy, and then 40% develop symptoms after pregnancy. So if we're only screening at that comprehensive postpartum visit, we're missing an opportunity to intervene earlier. But also, if we're only screening in pregnancy, we're missing patients who present later. So next slide. So this is why the AAP recommends screening by pediatricians for maternal depression at the 1, 2, 4, and 6 month visits. Really, the pediatrician's role, again, is primarily screening and referral, but may include implementing first-line treatment. So next slide. So I'm only going to talk about 2 screening tools here because I know we're so limited on time. I know your time is valuable. We're really going to focus on talking about screening for depression, but I threw these other tools up there because they're validated, they're free, they're easy to use and score, and they're available in multiple languages. So next slide. And this shows some screens that are specific to the pediatric setting. So folks are probably familiar with the SEEK, the Safe Environment for Every Kid. It contains within it the PHQ-2. So the PHQ-2 is sort of a short version of the PHQ-9, which is considered a valid screen for depression. If that screen is negative, meaning it's a no on both those questions, then no further screening at that visit is necessary. If there's an answer to either of those PHQ-2 questions, it's recommended to go ahead and administer the full PHQ-9. Again, still a self-report measure, pretty brief, quick, easy to score. The SWYC includes within it, in those 1, 2, 4, and 6 month age-specific forms, mixed in with the developmental screening, it includes basically the Edinburgh Postnatal Depression Scale, or the EPDS, that's sort of included in there. I made a note here because this was guidance we got from Louisiana Medicaid. Since pediatricians can bill for screening for maternal depression, it's recommended to document somewhere that EPDS score and to note it as such if you're using the SWYC, so that pediatricians, number one, pediatricians can bill for it, but also it's clear that the screening's been done and what the results and plan is. Next slide. This just quickly shows, just again, those items that ask, those first 4 there that I pulled out about parenting stress, and then those last 2 are the PHQ-2. And then the next slide should show just the SWYC, just to kind of show, they call it on the form, it says emotional changes with a new baby, but it really is the EPDS. Next slide. All right, thanks, Jody. So the other question is how do we incorporate this into a busy pediatric practice with all the other screens we have to do? So these screens, a support staff member, a medical assistant, give the patient the form either on check-in or on rooming. They also can score it, so it doesn't need to be scored by a clinician. Where the responsible licensed healthcare clinician comes in is being made aware of the score and providing feedback to the patient and next steps, making a plan for next steps. I added a note here, both the PHQ-9 and the EPDS ask about suicide. So they ask about suicidal ideation. So it's not enough to just know the full score. You really do need to know what the score was for that last item in the screen. And the PHQ-9 is question number 9, and the EPDS is question 10, because the patient could have a score that doesn't indicate depression, but could be suicidal. And so it's really important to know that answer, because it requires any score other than 0 on that requires further assessment and discussion and a plan. And for the same reason, of course, the screen needs to be scored and interpreted prior to the family leaving. Next slide. A lot of pediatricians ask about how to introduce screening. Our family's going to be put off by this. We're asking them questions about their mood at their child's visit. This is just some general guidance around language that we found helpful. This can be given verbally. It can be included in written form on those screening forms that patients receive. But we ask these questions. We ask all of our families these questions because these mood changes are really common and they can affect your health and your baby's health. Thank you for completing these questionnaires. Your answers are going to help us figure out how to help you. These changes can occur at any time in pregnancy or postpartum. And so we're going to ask you again. So it sort of prepares families that it sends the message, this matters, this is important, and this is a place where we can talk about this, if not today, the next time. Next slide. Interpreting screening results. So important to remember, screens are just one element of your assessment. They are not diagnostic. A negative screen just means lower likelihood of having clinical depression. Remembering even valid screens can have up to 20% false negative rate. So trust your clinical judgment if something in the presentation doesn't match the screen. A positive screen likewise just reflects a higher than usual probability and it warrants some sort of plan. Next slide. So I bring this up because it's really important to address negative screens. And I think we don't often do this. I think often we say, oh, great, glad that screen's negative, check that off the box and put it aside. It's really important to address even negative screens because it keeps the door open and it lets families know this matters. This wasn't just some form you filled out. This matters. So thank you so much for filling this out. Your answers indicate that you're unlikely to be experiencing depression at this time. But we ask everyone these questions because it's common and it's so important that we be able to offer help. So it keeps that door open, assuming that maybe that family member just wasn't ready to share today, but it keeps the door open so that they know they can discuss this. It's also a great opportunity to highlight strategies that maybe are helping to maintain wellness. So I'm glad to hear that you're not struggling with your sleep. What's been working for you? Oh, great. Continue to ask for help with those nighttime feeds. Your sleep matters. It's really important. So it gives you an opportunity to have those discussions too. Next slide. And then addressing a positive screen. So again, thanking patients and validating and reinforcing their disclosure. It sounds like you've been having low mood, you've been stressed, and I'm worried that you may be depressed. This is common. It's not your fault. You and your baby deserve for you to be well. There's some options that exist. Would it be okay if we talked about those? So asking permission, providing validation and support are all elements of addressing positive screens. Next slide. So I just wanted to mention this very briefly. So in cases where the person doing the screening, the clinician doing the screening might be initiating pharmacologic treatment, I make this point because studies suggest, the research we have suggests that the postpartum period actually carries the highest lifetime risk for bipolar disorder. So what that means is that when patients present with a new onset mood episode, including a depressive episode in that postpartum period, they are at higher risk for having an underlying bipolar illness. We don't fully understand why. There's something about pregnancy, but it means that we want to make sure that we're screening for bipolar illness before initiating a treatment like an antidepressant therapy. The reason being, antidepressants aren't the treatment of choice for patients with bipolar illness. Not only are they unlikely to work, they can make things worse. And so we suggest screening first before implementing treatment. The MDQ, the Mood Disorder Questionnaire, is a validated self-report screen. It's free. And it basically screens for kind of risk for a lifetime history of bipolar disorder. We advise folks that if that score is positive, it suggests further psychiatric assessment may be necessary before starting treatment, or give us a call and I'll share our number too. Or give PPCL a call. They know how to get in touch with us and we can talk further. Next slide. Pediatricians have asked too, well, what about cases where I screen the mother for depression and she says, oh, she's positive, but she says, oh, but I have a primary care doctor who's prescribing me something. how do we respond to that? So first is reinforcing again the disclosure and the patient taking care of her mental health. So glad that you've been able to talk about this with your primary care doctor, but it's okay to ask, do you feel like that medication's helping? Is it working well? Are you having side effects? Sometimes patients say, you know what, actually, to be honest, I kind of stopped it after a week because it was bothering my stomach and I didn't think it was helping. And that gives an opportunity to say, I think that's really important for your primary care doctor to know about this. Often medication adjustments can be made to ensure that it's working well for you. And we encourage pediatricians too, I'm sure you've done this before, with the patient's permission, to call and coordinate care with the primary care. The other that we have as part of our program, the next slide, it's called our Screen Passport. This actually comes from the world of pediatrics, but we sort of adapted it. This is a way for patients to kind of take ownership of their screening results. So in this healthcare system we're stuck in, where there's multiple different EMRs, it's so hard to coordinate care. We have siloed child and adult systems. This is a way for, if patients are getting screened by their home visiting nurse, getting screened by their child's pediatrician, they can take those screening results to their primary care doctor and have a discussion around it. And so that's available on our website, but I'm also happy to just send it out. Next slide. I know I'm rushing through these. I'd be remiss if I didn't mention, but I know that this is a topic I'm sure y'all have discussed about our infant and early childhood interventions and parenting interventions, including home visiting. So I'll save that because the experts really are your PPCL team to talk about those options, but consider it for your families where caregivers are experiencing stress or depression. They may be at risk for those relationship problems that could impact child's development. Next slide. This is just a note. We have a lot of clinical guides, clinical tools on our website. They're free to access for anybody. So if you find any of those helpful, take a look, including about weighing risks and benefits of SSRIs in pregnancy, sleep hygiene, some of those important elements. Next slide. Can't remember what I put here. So these are some great resources. And what I'll do, I'll go ahead and just copy these links and put them in the chat. These are just really trustworthy resources for information. Postpartum Support International, they have a number of online support groups. They also have a hotline that I'm going to put the link to in the chat as well. And MCPAP for Moms, a program after which we're modeled, but also MGH, Mother to Baby, and LactMed are excellent resources. Really good evidence-informed information about medications in pregnancy, about other pregnancy-related concerns. And then let me throw, and I think that's all I have. I'll just put these in the chat, and then I'd love to hear if y'all have any questions, comments. I ended right on time, Jody, I hope.
Oh, you're awesome. Thank you. Great. We have about a minute left for questions.
Okay. Thank you, Lena. I didn't put our number and contact in there. Thank you, Lena.
I have a question.
Sure.
We screen, we do the EPSD, but we don't do all the other two. I know that because the recommendations for Bright Futures is just to do the EPSD. Should we be doing this? Do you think that's more effective? I mean, I feel very uncomfortable. I would feel very uncomfortable prescribing or treating any of my adult patients. However, half my patients are now my mothers, so that's how long I've been in practice. So I feel like I'm kind of in a catch-22 because I did treat them when they were younger, and so should we be doing this seek, and if you have that, can I get a copy of it?
Oh, I certainly can. So first of all, if you're screening with the EPS, that's fantastic, and yes, that's validated screen in this population. It's also validated in dads as well. The recommendation in the non-birthing parent is maybe to use a lower cutoff score. But so it's great that you're screening, and no need to do another depression screening like the PHQ-9, the EPDS. The SEEK can make it easier because it asks about other things related to safety and parenting stress. But to me, the best screen is the one that you're going to use consistently, and that's validated, and that's really the goal, and that's going to get patients to the next step. The MDQ, again, it's really only if you're starting pharmacotherapy for a patient. I think that's really where I'm recommending it. It's a lot to ask to be doing multiple screens. I think the key is that doing a depression screen, and then and then the next steps, right? The referral piece. And I don't know where you're usually referring, or if you, I'm sure you find barriers all the time when trying to refer patients, but I think that's the critical element, is just screening and then referring where appropriate.
I'm pretty lucky on my primary care. My babies, we have primary care adult providers in clinic with us, and they'll usually convert over and see that patient right away.
That's great.
And see where they need to go and if they need to see psychiatry. So
That's wonderful.
I've used that PSI hotline for providers. It's awesome.
Yeah.
And they're collecting data on mental health medications in the postpartum, prepartum period. So they're very helpful.
They're great. It's a new hotline. I mean, they've always had a warm line. So Hearst is now funding this hotline. It's 24/7, and they do train their counselors. So it's another option. It's not treatment, and it's not a crisis line. And so 988 is still the suicide crisis line, but it's just a great option, because if it's 3 a.m. and you're a new mom and you're just completely overwhelmed, it's a warm person to talk to who's trained to provide support and validation and to help with next steps and resources. So it's a great resource. Absolutely.
All right. Thank you so much, Dr. Pinelli. It was good to see you.
Likewise, it was great to see you all. Thanks for jumping today. Appreciate it.
Great job.
Feel free to contact us with any questions.
So thank you very much for Dr. Queen and Dr. Pinelli. What we're going to do is we'll send, like usual, tomorrow I will send the link for the CEU questionnaire for those that need CMEs or CEUs, but I'll also include the PowerPoint, and I'll also include all of the links to both the algorithm that Dr. Olivier spoke of, as well as the screening passport, the Tulane website, and then all of those resources Dr. Pinelli mentioned. So this is the end of cohort 1 for this PPCL tele-echo. We do have a schedule that starts in May for our second cohort, and it's on our PPCL website. Here's the website right here that has the topics and the presenters, so that you can see if that is interesting for you. And then what we will do moving forward is just hope that you will join us for our next cohort. But I appreciate everyone's time and contribution for the discussion today. Thanks to everyone, and have a